Hi folks, let's talk about vulvitis. Several questions that were misunderstood by you. Not dermatoses, but vulvitis. Dermatosis we finished, thanks God. So now we talk about vulvitis. So take your pens, papers, and let's talk about vulvitis. Okay, inflammation of the vulva. So external female genitalia, including the labia majora, labia minora, clitoris, and vestibule. So it's a common complaint that can significantly impact a patient's quality of life. So let's try to understand diverse etiologies and clinical nuances. That is crucial for your exams and actually for future medical practice. And let's go on. Let's start. First of all, vulvitis, it's a symptom. I repeat, vulvitis is a symptom, not a standalone disease. So vulvitis itself is not a specific disease, but rather a clinical sign or symptom indicative of an underlying condition. So it's it's analogous to how headache can be caused by myriad issues, from stress to brain tumor. So the inflammation is the valvular response to an insult. Okay? Good. So why it's so important clinically? This means a clinician cannot simply diagnose vulvitis and stop there. You will be asked about that. A thorough history, physical examination, and sometimes further investigations are paramount the root cause. Okay? So treatment must be directed at underlying etiology. For example, antifungal for candidiasis, we will talk. Allergen avoidance for contact dermatitis. Topical steroids for lichen sclerosus. We used to talk about that about when we used to talk about dermatosis, but maybe we'll repeat. Treating only the inflammation without addressing the cause will lead to recurrence or persistence. So, explaining this to patients, not to lady, helps them understand why a simple cram might not be the answer and why further tests or lifestyle changes might be absolutely necessary. Next, a significant portion of vulvitis cases, especially non-infectious ones, are due to irritant contact dermatitis, ICD, irritant contact dermatitis, or allergic contact dermatitis. Common culprits include soaps, detergents, feminine hygiene, sprays, douches, scented toilet paper, sanitary pads, spermicides, what else? Lubricants, synthetic fabrics, and even urine or feces, especially in cases of incontinence or poor hygiene, unfortunately now very often. Overwashing, another point, another hand, can strip natural protective oils, a protective microbiome, exacerbating irritation. Why it's so important? History is a key. So a meticulous history of hygiene practices, product use, including new products, so-called, and sexual practice is vital. Patch testing for persistent or suspected allergic contact dermatitis. Referral for patch testing can identify specific allergens. For example, fragrances, preservatives like methylsotiazolinone, nickel, and the management focus. The cornerstone of management is identifying and eliminating the offending agent. Patient education or gentle valvular care, for example, using plain water or mild non-soap cleansers, avoiding harsh products, wearing cotton underwear is crucial, my beloveds. Next, while Candida albicans, so this is a vulvovaginal candidiasis, is a very common cause of infective vulvitis, it's far from the only one. Bacterial infections, for example, Streptococcus A, group A Streptococcus, Staphylococcus aureus, viral infections like herpes simplex virus, human papillovirus causing warts, and parasitic infestations like scabies or pediculus pubis lice can all present with vulvitis. Trichomoniasis, a sexually transmitted infection caused by Trichomonas vaginalis, frequently caused vulvovaginitis. Clinical importance of that, my beloveds. Clinicians, not you actually, and on the exams you will be asked about that, must consider a wide range of infectious agents, especially if initial antifungal treatment fails. Appropriate diagnostic tests are crucial. So wet mount microscopy and potassium hydroxide, CalOH, prep for Candida and Trichomonas, bacterial cultures if secondary infection is suspected, viral polymerase chain reaction PCR, or culture for herpes simplex virus, visual inspection of warts, scabious burrows or lice. So, and partner treatment. Even sexual transmitted, you will be asked about that. If a sexual transmitted infection is diagnosed, partner notification, husband, and treatment are essential to prevent reinfection and further spread. Okay? Many systemic or localized dermatological conditions can manifest on the vulva, leading to chronic and distressing vulvitis. Key examples: lichen sclerosis, no, it's dermatoses. Huh? Once again, we repeat the topic. So, an autoimmune condition causing intense itching, soreness, pale white, thin or crinkled skin, and potential scarring leading to fusion of labia and narrowing of the introitus, vaginal opening. This is like lichen sclerosis. Lichen planus, another autoimmune condition that can cause erosive erosive papilla or hysteroscopic lesions on the vulva and in the vagina, often associated with severe pain and burning. Eczema, atopic or seborrheic dermatitis, can cause itchy, red, and sometimes weeping or scaly patches. Next, psoriasis can present as well demarcated erythematosus plaques, often without the typically silvery scale seen elsewhere. Why it's so important? Biopsy, my beloveds, is often necessary. These conditions often require a valvular biopsy for definitive diagnosis, especially if empiric treatments fail or there is a suspicion of malignancy. There are often chronic conditions requiring long-term management, typically with potent topical corticosteroids. For example, clobetasol propionate for lichen sclerosis and lichen planus. Malignancy risk: untreated or poorly controlled lichen sclerosis and erosive lichen planus carry an increased risk of developing valvular squamous cell carcinoma, necessitating regular follow-up. Now, leukoplakia. Leukoplakia is a clinical descriptive Leukoplakia is a clinical descriptive term, not a specific diagnosis at all. It's a descriptive term. It literally means white plaque, from Greek leukos, white, and plaques, plate, flat surface. So, and refers to a white patch or plaque on the valvular skin or mucosa that cannot be rubbed off or attributed to another diagnosable disease or clinical appearance alone. It signals the need for further investigation. Why it's so important? So valvular leukoplakia can be caused by a wide range of conditions, including Benign inflammatory conditions, most commonly lichen sclerosis, chronic dermatitis with hyperkeratosis, thickening of the outlet layer of skin, post-inflammatory hypopigmentation, loss of skin color after inflammation. Vitiligo, though this is a depigmentation, it can present as a white patches. It's autoimmune disorder. Actually, why not dermatosis as well? No, this is not the point of today's topic. So, significant malignancy concern. Crucially, leukoplakia can be a manifestation of valvular intraepithelial neoplasia, VIN, or VIN, VIN abbreviation, which is a pre-malignant condition or even invasive valvular squamous cell carcinoma. Differentiated valvular interepithelial neoplasia, DVIN, which is often associated with lichen sclerosis and carries a higher risk of progression to cancer, frequently presents as a white thickened plaque. Biopsy is almost always mandatory due to potential for underlying premalignancy or malignancy and persistent unexplained area of valvular leukoplakia, especially if new, thickened, fissured or ulcerated, warrants a biopsy for definitive histopathological diagnosis. This allows for accurate diagnosis and appropriate management, which could range from topical steroids for lichen sclerosis to surgical excision for valvular intraepithelial neoplasia or valvular squamous cell carcinoma. That's why my beloved actually will be asked about that. So clear communication is vital to patient, of course, to explain that leukoplakia describes what it's seen, just what it's seen, and biopsy is needed to understand why it's there, what is beneath, okay? About hormones. Fluctuations in estrogen levels significantly impact vulvovaginal health. Low estrogen states, most notably in genitourinary syndrome of menopause. Genitourinary syndrome of menopause, right, GSM, previously known as atopic vaginitis, or just vulvitis, lead to thinning of the valvular and vaginal epithelium, induced elasticity, decreased lubrication, and altered vaginal microbiome. This makes the tissues more susceptible to irritation, trauma, and infection. Why it's so important? So, consider in postmenopausal women, valvular symptoms, dryness, itching, burning, dyspareunia. Is this demographic should raise suspicion for genitourinary syndrome of menopause? Treatment options: local estrogen therapy, creams, pessaries, rings, is highly effective in reverse atopic changes and alleviating symptoms. Non-hormonal moisturizing and lubricants also play a role. Why not? So while genitourinary syndrome of menopause is common, other causes of vulvitis must be excluded in this age group, especially lichen sclerosis or malignancy. Okay, my beloveds. Vulvitis, or commonly vulvovaginitis, is the most common gynecological complaint in prepubertal girls. Pediatric vulvitis paradoxes. However, the causes often differ from adults. Poor hygiene, for example, whipping back to front. Chemical irritants, bubble bath, soaps, tight clothing, foreign bodies like toilet paper. Don't be surprised. And parasitic infections like pinworms, Enterobius vermicularis, are more common. Specific bacterial infections can occur, but candidiasis is less common before puberty due to lower estrogen levels. So why it's so important? You will be asked about that. Management involves education on poor hygiene, avoidance of irritants, and treatment of specific causes. For example, mebendazole for pinworms. And largely sufficient, I suppose, for this point. And don't forget about parents, because parents often need reassurance that most cases are benign and resolved with just simple measures. Biopsy. While many cases of vulvitis can be diagnosed clinically and leukoplakia almost always needs one, a valvular biopsy remains an indispensable tool for any valvular lesion when the diagnosis is uncertain. Symptoms are refractory to standard treatment. There are atypical features: pigmented, ulcerated, persistently erythematous, indurated, or there is a suspicion of valvular intraepithelial neoplasia, VIN, or invasive cancer beyond just white patches. So you will be asked about that. Histopathologic definitive diagnosis. Histopathology provides a definitive diagnosis for conditions like lichen sclerosis, lichen planus, valvular intraepithelial neoplasia, and squamous cell carcinoma, and can differentiate various forms of dermatitis. So the biopsy is the guiding treatment, actually. The biopsy result directly influences the treatment plan, which can range from topic steroids, just nothing, to surgical excision or other oncological interventions. And timing is critical, my beloveds. Delaying biopsy in suspicious cases, not just leukoplakia, but any concerning lesions, can lead to delayed diagnosis of malignancy, potentially worsening prognosis. A low threshold for biopsy is recommended for persistent undiagnosed valvular lesions. Psychological and sexual impact. Chronic vulvitis can have a profound negative impact on patients' psychological well-being and sexual function. Persistent itching, pain, and soreness can lead to anxiety, depression, sleep disturbance, social withdrawal, and a significant reduction in quality of life. Dyspareunia, painful intercourse, is a common consequence, straining relationships. And clinical importance. You will be asked about that. Clinicians should inquire about the impact of symptoms on mood, sleep, daily activities, and sexual health. And we do not forget about an empathic approach. Acknowledging the patient's distress and validating their experience is crucial for building trust and adherence to treatment. And referral to psychologist, why not psychotherapist, actually highly questionable, controversial, but anyway, or pelvic floor physician therapist may be beneficial in managing the broad consequences of chronic vulvitis. That is multidisciplinary care, definitely. Ironically, attempts to treat valvular symptoms can sometimes worsen or cause vulvitis. This can happen through overuse of topical antifungal steroids, leading to skin thinning, secondary irritation or masking, and the true underlying condition. Next, allergic reaction to prescribed creams. The excipients, inactive ingredients, inactive ingredients in a medication can themselves be allergens. Yeah, I'm not joking. Next, excessive cleansing regimens. Patients may adopt aggressive hygiene practice, hoping to alleviate symptoms, thereby perpetuating irritant dermatitis. Why it's so important? Review current treatments. Always ask about all products being used, including over-the-counter and prescribed medications. Avoid prescribing multiple topical agents simultaneously without a clear diagnostic, as this can confuse the clinical picture and increase the risk of irritation or sensitization. So educate on gentle care. Reinforce the principle of gentle valvular care even when prescribing active treatments, my beloveds. Very important point. Maybe one of the most. For me, it's the most. Microbiome mystery. Yes, while the vaginal microbiome is extensively studied, Research into distinct valvular microbiome is an emergency field. It's understood that the valvular skin has its own unique protect microbiome community, which plays a role, a significant, a major, a principal, a crucial role in maintaining health and protecting against pathogens. So this biosis imbalance, sometimes pronounced dysbacteriosis, up to you. So this biosis in this microbiome, this imbalance, could contribute to certain types of vulvitis. We can say all types of vulvitis and dermatoses, or increase susceptibility to infections. Why it's so important? Understanding of the valvular microbiome may lead to novel diagnostic markers or therapeutic interventions, actually ancient therapeutic interventions, such as targeted probiotics or prebiotics for valvular health. For some patients with recurrent, seemingly idiopathic vulvitis, alterations in the local microbiome might be contributing factor, though this is still sometimes speculative. And this highlights an area of ongoing research that could revolutionize our understanding and management of valvular conditions. Microbiome, not only here, in this area, realm. All candidiasis, vulvovaginal candidiasis. So, although Candida albicans is a commensal, so that is normal inhabitant of the vagina, is approximately 20% of healthy reproductive age women, symptomatic vulvovaginal candidiasis develop when there is a disruption of microbial balance or predisposing factors are present, leading to fungal overgrowth and inflammation. Not all Candida species are equally pathogenic or susceptible to standard antifungal medications. For example, Candida glabrata is often more resistant. So, classic symptoms: intense valvular and vaginal itching, pruritus, burning, soreness, valvular edema and erythema, as well as characteristic thick, white, cottage cheese-like discharge without odor. Though discharge can vary. Dyspareunia, painful intercourse, and dysuria, painful urination, usually external, are also common. And my good advice to you, nobody will explain that to you. So very good advice are two to a lady. Drink a lot of water. A lot. Water, not juices. Water. Tea, but without sugar, of course. It's okay as well. And avoid sugars, especially sucrose, white meal, and starch. And in once there will be no more so-called vulvovaginitis, candidiasis. Okay, so diagnosis: saline wet mount and 10% potassium hydroxide microscopy allows visualization of pseudophia and pseudohetha and budding yet cells. The sensitivity of this method is 50 up to 70%. Vaginal pH, usually normal, less than 4.5, which helps distinguish it from bacterial vaginosis or trichomoniasis, where pH is typically elevated. Fungal culture recommended for recurrent vulvovaginal candidiasis. 4 or more episodes per year. Atypical symptoms: failure of standard treatment or to identify non-albicans Candida species. Risk factors: pregnancy, diabetes mellitus. We talk about sugar above. Especially uncontrolled. Recent antibiotic use of immunosuppressive drugs, including corticosteroids, high estrogen levels from high-dose estrogen oral contraceptives, certain sexual practices, tight synthetic clothing. So how to manage? Uncomplicated vulvovaginal candidiasis usually responds well to short course of topicals, azoles, clotrimazoles, miconazole, etc. as creams on suppositories or a single oral dose of fluconazole. Don't forget 2 things: drink a lot of water and avoid sugars, sucrose, white meal, starch, and you will be surprised. So complicated vulvovaginal candidiasis, that is recurrent, severe, in immunocomplicated patients as well, especially caused by non-albicans species, requires longer courses of treatment, sometimes maintains therapy. And recurrent vulvovaginal candidiasis present a diagnostic and therapeutic challenge requiring exclusion of other diagnoses, identification and correction of the predisposing factors, and often long-term suppressive therapy. But it's always, in 99%, it's dietic challenge. Dietic. Once again, a lot of water, 2 liters a day. Not for one time, huh? 2 liters in 24 hours. Normal water, plain water. And avoid sugars, white sucrose, white meal, and starch. That's it. So, largely sufficient for your excellent answer. So, actually, I clarified all questions that I've seen these previous years that you've sent me concerning, and I was present at your big board exams these several years. These questions, I suppose, I clarified. I hope it will be helpful for your big board exams. God bless you. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my Telegram private channel, Dr. Y. So I also got private. It's not costly at all. WHY, Dr. Y. See you in the next lectures. Bye-bye and God bless.